We use this method to monitoring these circulating cells during or after therapy. This makes it possible to monitor the therapy and directly the tumor activity, and it's an additional tool to optimize and personalize therapy. And this first case is a patient who did not do any conventional therapy, not even a surgery, and he was on watch and wait. He had a low malignant tumor, and we monitored him after he started, and with complementary therapy, nothing else, his cell numbers dropped, remained low for several times, and then now it starts increasing. This is still at a low level, but it should be monitored further, and maybe the complementary therapy might be changed, or if the patient is anxious, he can do additional imaging to see whether his tumor grows. But he's 62 years old, so this tumor may take a long time to grow and even more time to develop metastasis. We have also analyzed cells in prostate cancer during radiotherapy, because this is a frequent therapy which is used to treat prostate cancer. There are no reliable biomarkers to predict recurrence after treatment. This study has evaluated whether CTCs in blood can serve as such biomarker. Radiotherapy is often used either after surgery or as definitive therapy, and we analyzed 52 prostate cancers. It's often discussed whether surgery should be performed because it has severe side effects, even a short time and long time, and maybe the radiotherapy is less intensive. So we collected samples before, during, and after radiotherapy and determined the CETC counts. In most cases, the cell numbers decreased during radiotherapy. Also, radiotherapy is only a localized therapy, but in some patients, as you can see, cell numbers increased from the nadir midterm radiotherapy until post-therapy. And we could show that if the numbers increased, that's the pink line, then there was a high probability for these patients to suffer relapse as compared to patients where the cell numbers did decrease or stay low. The increase is strongly associated with a higher relapse risk of 8.8-fold. So at that time, still during radiotherapy or shortly after radiotherapy, the patient can talk with his treating physician what to do if he has increasing cell numbers in order to prevent relapse. The monitoring during radiotherapy can provide a valuable prognostic information and may identify patients at higher risk of recurrence more effectively than PSA can. This again is another patient, and now this patient had already suffered relapse. He received radiotherapy after surgery, and he also had a low Gleason, low active tumor, but still suffered relapse 1 year later. He was treated with radiotherapy. His cell numbers fell, and he was subsequently treated with GnRH analog combined with complementary therapy. And as you can see, he remained at a stable low level. And this was consistent with clinical remission, and he is still in clinical remission until now. Another patient who was diagnosed in 2007 had a relapse after radical prostatectomy in 2010. He was then treated with radiotherapy and with bicalutamide. As long as he was treated with bicalutamide, his cell numbers remained very low. But after stopping therapy, there was a massive increase in circulating tumor cells. This reflects disease progression, and he also had a biochemical relapse. So do you have any questions with regard to these few clinical cases?
Here is one question. If the cell numbers are relatively high under watch and wait, not decreasing as seen in case report 1, how should this be interpreted?
Well, as I mentioned, they did increase. The number itself is not the important issue. It's the increase. And in this case, we would suggest that the patient maybe changes his complementary therapy, which may be not sufficient. But otherwise, we would suggest that he takes imaging to see whether the tumor has grown. As long as he does not have clinical symptoms, he can stay, if he wants, on watch and wait. But this should patient discuss with his treating physician.
The second question, when should circulating tumor cells be tested, after or during radiotherapy?
We did this analysis before, at the mid, and at the end. And we would suggest to do this because it's obviously the cells are first eliminated, and then the remnants few cells can regrow, and this is a sign of increased probability of relapse, not the number per se.
One question, can you tell us more about the GnRH analog? Does that often have very good results that you found in this patient?
We see very good results, but it's also impairing the patient's life conditions. So many patients would like to stop, and maybe it would be a good idea to stop for a while and then reinitiate if cell numbers start increasing. So it's also up to the patient whether he wants to take this therapy or not.
Thank you very much. That's all currently.